Hello everybody and welcome to the Performance Health webinar on Around the Thumb in 60 minutes, which of course we can't really do in 60 minutes, so I've chosen, I think, some really nice little clinical nuggets that will be able to draw on lots of different bits of equipment and different treatment modalities to help us just consider a few bits that are integral to treating the thumb. So I'm going to start by having a look at measurement of pinch strengths, which I think is something that we all find quite difficult. We're good at doing grip strength measurements and very familiar with the equipment, but less familiar with the pinch strength measurement. So I have my really lovely pretend patient with me here today, who's going to allow me to do all sorts of things, split her, cover her in tape and whatever. We're going to start by having a look at her pinch. Now, I'm actually going to do everything on her right hand, but you would do exactly the same on her left. Because she's actually hurt her thumb on the left, so we're not going to do that. So I'm using the B&L engineering pinch gauge, and it's important that if you want to compare your results with the normative values that are out there, and yes, there are multiple ones, but really in the end, still the golden biggest population was done by Matthews back in the 1980s. And so those really are the norms that most people are still using, and those were done with the B&L pinch gauge. Now you might ask, well, hang on a minute, in my department I've got the baseline pinch gauge, which looks very similar, or I've got the JMAR one, which is the round disc that looks like the head of a JMAR grip, but with a little button. You can't interchange. So first of all, you can't swap between one tool and the other because they're not equivalent, and you also can't use the norms unless you're actually using the B&L engineering pinch gauge. So just alert, this is the one we're going to be using. So I'm going to place my lovely assistant here in the right position. So we're going to have the shoulder adducted, the elbow at 90 degrees, exactly the same position as you would be in when you're measuring grip strength. And I'm going to ask her to be in that mid-prosupination position. So I'm going to measure 4 different types of pinch. And we all call pinch grips slightly different things. So let's also just consider the different way we can call these pinch grips. So we've got, first of all, the strongest pinch grip that the human hand has. So we're going to measure what we either call the lateral or the key pinch, and I'm going to make sure I place her hand with fingers in flexion and the thumb really gently in position over to the lateral border of the PIP joint of the index finger. And I'm going to bring the device to her. Now, first of all, I'm going to check on the dial and make sure that the 0 is 0. And if it isn't, you can actually rotate to get the 0 to exactly the right point. So I'm going to bring the device to her, and I'm now going to ask her to gently apply force. Now squeeze as hard as you can, harder, harder, stop. Beautiful, thank you. And then I can read off, and it's actually the lower border of the red little bar that you see that you'll be able to read off. Now, it's really important that we make sure we all hold the hand in the same way, so that we can actually exchange information when we pass our patients from one person to another. So the easiest way I always find is if we go with exactly the same position we use for measuring grip strength, because that's what we're all familiar with. So here is the strongest human pinch. And now these B&L pinch gauges come in a 0 to 10, a 0 to 30, and a 0 to 60 kilograms. Now, honestly, if you've got somebody who's over 30 and needs the up to 60, I would question why they're in your hand therapy clinic. They probably don't need you because they're super strong. If you're working in rheumatology or pediatrics, you might want to go with the 0 to 10, but with your basic, average, adult or mixed caseload, you really want to go with the 0 to 30 option. So that's how we're going to measure the lateral or the key pinch. So then I'm going to think about, well, I want to measure now her pure pinch. So by that, I mean either the palmar or pad to pad pinch, between the index and the thumb. Now, if I just measure her like this, what will happen is that these fingers will just come in and try and help. So hide the ulnar 3 digits into the palm and now bring the device into position so that it's comfortable for her. So I'm not going to ask her to hold it. I'm going to bring it to her so that we have that, maintain that mid-prosupination position. So again, same instruction, gently apply force. Now squeeze as hard as you can, harder, harder, stop. Beautiful. Now the one thing I'm just going to say, I've done it once, you won't do it more than once. Don't hold your BNL pinch gauge on the side because there is movement. And if you hold it on the side, you actually get squished. So make sure that when you're holding it, you're right down the base. It's important to hold it. You can put it around your wrist, because if you drop it, of course, then you're talking about recalibration. So here we have our pure or palmar pad-to-pad pinch. We also want to look at the tripod pinch. So that's between the thumb and the index and middle fingers. Again, curl the ulnar digits out of the way, bring the device in, gently apply force. Now squeeze as hard as you can, harder, harder, stop. Beautiful, fantastic, okay? Those are the 3 probably most common that you will do, but there's also the tip pinch. So, you know, as if you're picking up a grain of rice, really, really fine. So again, I'm going to hide these 3 fingers and I'm going to go for a real tip to tip. Gently apply force, squeeze as hard as you can, harder, harder, stop. And you'll find that that's the weakest of all of the 4 grips. Now, thank you, brilliant. What you might find is that you follow, again, the research, which says that if you take an average of 3, you're going to have a much more reliable result. So you might want to take an average of 3. But if you're doing all of the different pinch grips, then that's a lot. That's 12 repetitions. So fatigue will come in pretty quickly. So I think you need to make a decision. Do I measure 1 of each of the 4 or all 3 of 1 or 2 of them, just to be kind to your patient, or separated across different treatment episodes. So we're going to move up towards the table now. Lovely. And we said we would do round the thumb in 60 minutes. The 2 most common issues that we have on the radial side, base of the thumb, the 2 most common things you're likely to see, of course, osteoarthritis of the carpal metacarpal joint and decurvens or first compartment dorsal extensor tenosynovitis or tenovaginitis. We're not going to get into a conversation about what that disorder actually is right now, but let's have a look at how we would distinguish between them. So we're going to place your patient with their elbow on the table so they're nice and stable. And then we're going to examine the thumb. Now, I can see here that the thumb we're looking at is sitting in a beautiful position. If you were to look at my thumb, it wouldn't be quite the same. Can you see that my thumb sits slightly more, can you see that, Chris? In the palm. And this is called the shoulder sign. So you can see that my carpal metacarpal joint is just beginning to sublux into my palm. And that is a sign of osteoarthritis of the thumb, too many years of hand cramping, that's what it is. So the other thing, if I'm suspicious of OA of the thumb, I might ask my patient to put their 2 hands together, pop the other hand on if we can, and then just lift the thumbs up as far as you can. And just check that they're equal and check that you've got a really lovely C shape in here rather than a V. Now, if I just show you mine from the side, you can see already that my right hand, this one, I am unable to go as far as my left. So I'm beginning to get an adduction deformity in here and I'm losing my web space. Hardly surprising, I've had this arthritis for near on 20 years now. So all in all, it's doing pretty well. If I were to palpate in here, it would be painful. If I palpate in here, No pain whatsoever, which is lovely. So I would try those 3 things first. And if that's still clear, we can try the grind test. So I'm holding on to the first metacarpal and holding on to the radial carpal bones. And here you can see that I'm just doing a little bit of a rotation of the CMC joint. No compression. So start that first. Then if that's pain-free, I can push to compress the joint and now rotate the joint. And again, it's completely pain-free. If someone were to do that to me, then it would actually be painful. So that we've got as the grind test. So that will help you differentiate. Do we have osteoarthritis of the carpal joint or don't we? Might it be instead decurvens or the dorsal thumb extensor synovitis? So let's test our thumb extensors. So if I lift the thumb up from the table, that can only be done using EPL. So if I ask my patient to hold their thumb there and I put some pressure on it, so she's doing resisted EPL, if that is sore, see the EPL goes through the 3rd dorsal compartment. That's not decurvens, okay? But that might be indicated at the time, so just make sure you exclude that. Then let's look at the 2 muscles that go through the 1st dorsal compartment. So we're going to look at the short extensor, EPB. So we're going to ask our patients to bend the tip of the thumb and then extend back the thumb into a resistance. Push into me. Brilliant. No pain. Perfect. Lovely. Then open the tip out and push into me this way. So we're doing abductor pollicis longus. No pain there either. Fantastic. Okay, so we've tested the 3 tendons. And then we're going to do Finkelstein's. Now, this is one of those tests that you find on the internet wrong multiple times. So what do? We hold the thumb. Sorry, I'm just going to move so that you can see us. Move the thumb into the palm. I'm holding it there passively. Now, if that is symptomatic enough, don't continue the test. Don't go further. Then I'm going to ask her to actively on the deviate. So bring your wrist down this way, lovely. And if it's a positive test, you'll get a sharp pain along the radial edge, the back of the thumb. It's actually symptomatic in quite a lot of people. A lot of people are tight. So what you would do is you just test it against the other side and see if it's different. And that will help you differentiate. So we're going to concentrate on those 2 pathologies. Brilliant. We're completely pain-free here, which is lovely, which means I can do whatever I like with this hand, and I know I'm not going to be hurting her, which is ideal. So just a few taping ideas. So I've got some TheraBand tape here, and I've pre-cut the pieces. So I'm going to show you the little, I always call it the smile technique for CMC arthritis. This works really nicely for me. I had a patient yesterday who's got arthritis. He's a professional guitarist. And actually, just by putting this tape in place, he was able to play again with much less pain. It really does work. So I'm going to tear the tape down the middle and fold back either edge. And then I'm going to look at the thinner crease coming under here. Remember, on me, that carpal metacarpal will have sunk towards the palmar surface. So we're going to attach the tape here, give a little bit of an uplift, and then nothing on the anchor and nothing on the anchor. Now, of course, hands are very, very sweaty. So, of course, we would rub it to heat the glue to make sure that it really sticks very well. But actually, on the hand, it doesn't stick terribly well, particularly in the palmar area. So what I tend to do is just add a second piece. Just so that it stays, because tape sticks very well to tape. So if I start off on this volar aspect and bring it around and stick it back onto itself on the dorsal aspect, and all I'm doing is sticking tape to tape, then actually this piece is doing nothing other than securing this piece in place. And what you can feel is a really nice uplift onto that carpal metacarpal joint. So for someone who can't tolerate splints, which we'll come on and look at in a minute, this is a really nice little technique. Feels all right? Excellent. Right, I'm going to take it off because we're going to carry on applying lots of tape to you. Right. So that's one idea for MSC arthritis. Now we've got two ideas. Now, there are many, many, many different ways to tape. You don't need to do it as I'm doing it. I'm just giving you an idea. I'm going to show you a muscle enhance and a muscle inhibit way of managing the hand with decurving. So we'll start with the muscle inhibit. So when it's really acute and you want somebody to use use that hand less, to do less on the deviation, to do less strong pinch, then if you cut yourself a piece in the shape of a bottle, tape sticks really well to nails. So I actually quite like to start this right up by the nail because it will stick really well. Again, no tension on the anchor at all. Take off the central piece, and then we're going to radially deviate the wrist, extend the thumb, and make a little bit of a bridge. I'm just going to turn this tape over a little bit. So I'm going to make a bridge coming across. So I've got a gap here. Then what I'm going to do is I'm just going to gently roll the tape into position, very gently, making sure that it attaches, and then nothing on the anchor again, so we don't hurt the skin. The more you rub it, the better it will stay. Now, if you try and do a pinch for me, it gives a little bit of resistance, doesn't it? So it's reminding your brain all the time through proprioception, it's going, oh, don't do that, I'm not so sure about that. And particularly if you drop the wrist down into on the deviation, you get that resistance here, don't you? Yeah? Okay, so that's a quite nice muscle inhibit technique. Again, we're going to take the tape off. Hence, I didn't rub it too much. Okay. All right, haven't killed you off yet. Brilliant. Okay, and now we look at a muscle enhance version. So at this point, pain is beginning to go down. We really want the muscles to start working again well, because they haven't worked very well for a while. This time, we're going to follow the pathway of the muscle. So we're going to come across, so we know where these muscles go across, and they skirt across the forearm. So what we're going to do is we're actually going to start at the other end. You can start at either end, but I just prefer starting at the proximal end. I'll have quite often really done some work into those muscles first, had a feel of them. Of course, if you use oil or cream, you need to wash the arm first. Otherwise, of course, you can't attach the tape. So I'm just going to come across at the elbow here. Attach it. Again, I'm not going to go really rubbing this tight because I just want this to be able to come straight off again. And now we're going to straighten the elbow, drop the wrist down, and the thumb going a little bit of on the deviation. So the muscles on a stretch, and then just place with tape on, what do you call it? Tension. So you're not adding tension, you don't need to because you've already put the muscle in a stretch. And then we're going to come across. Again, no tension on either of the anchors. And this will sit, oh, stop rubbing it. Sorry. So this will sit over the arm and it will really help with the muscle working and getting back to working really well. So there's some ideas using kinesiology tape for the two most commonly seen conditions that we see in hand therapy clinics. Right, let's move on and look at splinting. Do you want to pop that off? I'll let you do that rather than me. I'm just going to put a few splints that I've pre-prepared into the splint pan. Okay, so I thought I'd show a couple of the patterns, because I know everybody always wants to know about patterns. So here I have some usual paper towel. So will you just place your hand down? Now, when you place the hand down, always be careful. Make sure that you've got, do you need to move a bit further in? Just be sure that you've got the wrist in correct alignment. So it's not radially and not ulnarly deviated. I'm going to use Sharpie so that in the hope that you can see it really well. I'm going to try really hard not to draw on your skin. So we're going to draw around forearm, the thumb. I know I'm not needing the fingers, so that's off the paper. I'm going to mark the MCPs, the IP of the thumb, MCP, CMC, and the wrist both sides. And then I'm going to ask you to lift off. So let's start with a long thumb spiker. Now, this could be used for decurvins. It could also be used for really painful OA CMC. So you don't want to have any splinting material getting in the way of the IP joint of the thumb, and you don't want anything getting in the way of the fingers. So you know you don't want anything there, and you don't want anything at this end. But we need a little lip that's going to come around the thumb to secure the splint. So I'm going to use the marks from where my IP joint is and where the web space is to indicate where I want to be. And then I imagine where my femur would have been, and I'm going to mimic this opposite on the other side. And then I'm going to come down following the contour of the arm. Now, obviously, it just depends on how big that person's arm is or not. So I've already cut this splint out, and I've already got it into the splint pan. So let me show you that. Let's hope that it's got soft. Okay. So here we have this splint. Now, I really like this lovely little trick. Take a little bit of scrap paper and ask your patient to pop their elbow here and just gently hold something. This puts them in their natural pinch position, which at least means that you've left them with a functional hand. And I'm then going to pop this little piece between the thumb here. This is tailor splint, by the way, which molds so nicely. I'm going to roll it down on the IP here so we get freedom of movement. And you can see I've done very little. The better your pattern is, it just fits. I don't need to do anything. I've pre-cut some nice pieces of hook Velcro. So I'm just going to attach these again. You can attach them while the splint is still hot. You don't need to preheat them. Now, if this is for decurvins, be a little bit careful putting this distal strap exactly over the anatomical snuff box, because sometimes if patients over pull on there, it can be a bit sore. And here I have my Velcro. Now I'm going to just fit the straps nice and gently. Make sure you fully cover the hook Velcro. There is nothing more irritating. Any of you who've worn a splint will know, nothing more irritating than leaving a little bit of the hook Velcro exposed, because it will catch on all your clothes. And that in itself is enough to stop somebody wearing the splint. Now, if you've got someone with a really swollen IP joint, you probably don't want this to stick. Now, because I don't have that, it's completely fine for it to stick. But again, a lovely little trick I'll show you on the next splint, so that you can make sure that this can be opened in order to allow her to function. It's quite hot in here, even though we haven't got the heating on. So this is still quite warm, so it's not quite hard enough. So I'll just leave that on there just for a little second longer, so that it can take its shape. It's always really helpful if you're working in a slightly cooler space, because everything just works a bit quicker. So make a pinch, check that the IP joint has got full bend. Can you fully bend down the tip of your thumb? So it's got complete freedom of movement. It doesn't get in the way here. and it fully supports the hand. Feeling all right? So here's our splint. Okay, so tailor slip's a really nice material to use for this splint because it's got enough integrity, but it's also really lovely and moldable. So we can also make a version of this that is much smaller and doesn't include the wrist. So this really would be needed for decurvants or any other way of doing so. But for osteoarthritis, you've got to think way more about the biomechanics. So, what should I do with this? Here we go. Let's make a little museum here. Right, so. Here I have polyform, again, one of the really moldable materials. And now if we've got a really, really nice and really little bit of support for the CMC and some immobilization of the MCP from my OA, that would work really nicely. Then you can make a short version, same places that I'm marking out for this little tab. So we're going to, again, place the hand in position. Make sure it's not too hot. You're right with the heat. Yeah. Okay. Now this time, here's the actual pattern. If I put a little bit of paper towel between this and here, it won't actually stick to itself. So that is a nice little tip. Again, I'm rolling it down, placing the thumb, just supporting it here, and just make sure at the proximal end that you roll it up a little bit so that you check that she's got full extension without it banging on the back of the forearm. This also adds a little bit of contour to give you that stability. So this splint can be made volar or it can be made dorsal. I will always make it dorsal unless there's a good reason not to, in order that we can really make sure that there's as much of the palmar area free. That really, really helps with function, so that when you're putting items in your palm, then it's free. Again, it's really warm in here. So it's going to take a while. So again, I've got a few of these pre-cut pieces here. Let's find a nice little one. So this is going to sit on that tab that I've built on the front here. This now isn't sticking. So then I'm going to put a little tab at the other end in the right direction. And now I can have a tiny little strap that most of the time will just stay done up. But on occasion, if the IP joint really swells, she's got to get out of jail free because she can undo it, undo that, and then there's more space because it hasn't stuck. So now all I need to do is put another piece of Velcro across, and then I would add another one, and my splint will go across from here around and stick onto the back. Okay, so that works really nicely. Now, obviously, you need to know what your patient's going to be doing when they wear this splint. Because if they're typing all day, you actually need to make it with the carpal arch quite open and the metacarpal arch quite open. If they are doing little fine pinch movements all day, you need to exacerbate that carpal and metacarpal arch. Or you need to have a stretchy piece of Velcro or a bit of neoprene in order that it can have that little bit of bounce with it. Now, what if this was a person with osteoarthritis, and when I supported supported the CMC, immobilized the IP, what it did was it hyperextended the IP joint. We really don't want that biomechanically. So we can make a little adaptation to this splint. Splint pan, I've done it out of Aquaplast, this one, which means it's gone see-through. Always helpful. Just pop these two in. Okay, so what if we had that scenario that the hand ended up with the IP joint going into lots of hyperextension? So again, I'm going to ask your patient to just gently hold something on my position. Here we go. Same pattern, all but one bit. So here I'll just attach this. Easier. And this is all the same, but this time I've got a little cap over the back of the IP joint. Now, why have we got that? In order that as she pinches, as she comes into extension, it blocks that extension. So we've got plenty of flexion, and I can roll it down. So the IP joint is really free to come into flexion, but when she wants to push against it, we've managed those biomechanics really well so that we are supporting all three joints of the thumb. We've got exactly the same. It's exactly the same on the back. Because it's see-through, it's a little bit more tricky for you to see it. It will go white, and then we'll be able to look at that. Now we can do exactly the same. We can have exactly the same principle with a support splint for the carpal metacarpal joint alone. So we can either just support that joint, or we can support it with a dorsal block of the proximal phalanx. So it's the same principles. And again, for me, that would probably be the most applicable, because when I support my CMC, and that really helps with my pain, but then when I put a pinch grip, you can see that actually I'm falling into hyperextension here of my MP joint. So I want to support the CMC and provide a dorsal block here, so that I've actually got, again, back to the proper mechanics of the thumb. And that requires a little bit of a dorsal block on the block of that proximal phalanx in order to do it. I'm going to pull this off, even though it's not quite dry. Okay. Yeah. So here is the more simple, straightforward carpal metacarpal joint support. Sorry, it's quite hot. Again, comes through into the palm, bring that over and onto itself, and make sure that there's really good movement available of the MP joint. So just make sure that that moves really well. And here's our splint. So this is very similar to the ones that you can buy off the shelf. If you're doing for a dominant hand, I actually would make it much shorter, like so. It doesn't come over this ulnar lip, because as you'll know, anyone who's tried to wear one of those splints that's off the shelf, this catches. So if it's a hand that you're writing with, you need to have this area sensate. Otherwise, that causes a bit of an issue. So here again, we've got a lovely, so I'm supporting the CMC, I'm supporting the subluxation, but good flexion allowed. So it's really nice for pain. Just got to blow it to try and get it to cool off. Has it got really hot in here? Yeah. Okay. So then you can do the same splint with an adaptation to put that block over the back. Now, if I show you the patterns for that, so here's my pattern for that simple one we've just done. What I then did was I marked on the back here where the alignment is of the dorsal aspect of the proximal phalanx. And then I made a second one, which is exactly the same, but with this dorsal piece, because I knew the angle that that was coming off. And I find it's much easier. Make the basic pattern, mark on it, and then add a piece on and check it. Like I said, lots of little hints and tricks. Some might call it cheating. And here we go with Taylor Splint again. So this was with Aquaplast watercolors. So all of these materials I've chosen, because it's the thumb, I've chosen materials that have got really nice conformability. They mold really, really nicely. So we want to manage the laxity. We want to manage, you can use this for hypermobile patients potentially as well. Sorry, I just saw a tiny pen mark and I'm utterly allergic to pen marks. So that had to go. So here we have the same scenario. If I don't want this to stick, I'll just put something in between the two layers. Here's my splint. And now I've got roll down on the roller surface to get good MCP flexion. And I've got a dorsal block. Again, pop in the pinch position. That's lovely. In order that it's going to fit really well. Again, just always check these hand-based ones. If you roll it just at this end, first of all, it gives that extra contour, which will give you extra integrity and strength to the splint. But we're just making sure that when she extends, there's nothing that actually bangs against the forearm here. Have that dorsal block. Now, one thing to be very aware of with all of these splints is we've got the dorsal sensory branch of the radial nerve here, and this can be irritated sometimes by splints or by straps. So just be very aware of anything that finishes around that area or has a strap across. And if you have a strap across this area, always make sure the Velcro is absolutely flat, not, I know this isn't Velcro, it's K-tape, but for illustration purposes, if it's slightly on an angle, you can actually cause an irritation of that nerve. So always make sure that you're really flat to it. And again, here we would have a nice strapping system. Okay, to bring this from this side. I always attach one Velcro first. Oh. And then I make sure that I check on the angle, because every patient is different. So I then check on the angle and I go, well, where is this the most comfortable for her to be sitting? And then attach the second piece in that orientation. Don't put both on first. So here we go, across. And that is really comfy for her. Again, if it's a right hand and she needs to write, I would probably not bring the splint quite so far around the hypothenar eminence so that you can actually feel the hand against the paper if you're writing. Makes a huge difference to function. Okay, so that is a major whiz around different splints for the thumb. So the splint pen. Here we go, all five are sitting behind us. So if anybody asks questions about them, we can just retrieve them. But I thought I'd also show you some exercise equipment and a little bit of ADL equipment as well. So I've got two little bits of exercise equipment here, both of which I really love for working the thumbs. Now, we're talking again about osteoarthritis. If we're talking about osteoarthritis, we want to make sure that the first thing we do is stabilize the thumb. We want the movement to be good. So for me, with my unstable MCP joint, to start with, if I want to try and do a little bit of strengthening, I'm going to take the IP joint out of it. I don't want FPL to be part of what I'm doing. So I'm really just pushing forwards, pushing around with and from the MP joint and building in opposition, so circumduction around. So I want to work like so, but I want to make sure that I don't let that joint drop into hyperextension. So sometimes I teach my patients when they first start to try and strengthen up or just get stability, it's a very, I mean, there's barely any resistance from this putty at all. It's the soft, soft, soft one, and I'm supporting my joint underneath. So I'm just beginning to work my stabilizers of the thumb without the tip of the thumb and without the hyperextension here. Now, as I get better and better at it, I won't need to stabilize it with my other hand. You can do all sorts of things. You can hide marbles into the putty and people can work on their pinch, but you can see as soon as I go to pinch now, I'm falling into that abnormal pattern. So I've got more work to do to maintain that before I can go to real strengthening. For me, it's about stabilization to start with. But then you can also use these really lovely sponges. Now, before you all go crazy and say, yes, but I can't get them, they will be back within, we hope, a month. I think that's fair to say. The first shipment that will be back into the UK will be in about a month's time. So get your back orders in, guys. But I'm already ahead of you, just so you know. So these work, okay? Yellow, then pink, then green, then blue, then green. So you can build up. They're just so much more convenient sometimes for people to take out and about than putty. They don't leave residue. They're easy to put in your pocket. And again, you can do all of your exercises. So I'm not using my IP joint. I'm working just on the MP joint. I'm working into circumduction, maintaining control of that joint. And I can work my way up against more and more and more resistance. So there we go, quick look at some different exercise routines. And then I thought I would also bring the OT out in me and just show you a few bits of equipment that work really well, again, for OA, but also really important if someone's got decurvents, we need to think about how do we reduce the impact of the forces through the thumb. Now, I got a bit of a surprise when I just opened the roll of Dyson that I was sent, because it's sparkly silver. Who knew? So we're going to take pieces of sparkly silver Dyson. This is the most useful bits of equipment. So people can just keep a bit of this in their pocket or in their bag. And if you're wanting to twist off a lid, for example, as soon as you put a piece of Dyson over it, the resistance, I can literally do that now with my palm, rather than really tight working with my thumb. So it will just reduce the effort with everything you do, everything from turning taps, with the handbrake in the car, with you know, anything that we're doing with force. A little bit of Dyson can really help, as can one of these little devices. So we could use these to open lids. Again, it's in a much better position. My hand's in a lovely functional position here. And I can very easily, obviously the effort to undo this, because it catches in the rubberized bit here, is almost nothing. And those of you who know me well know that I'm completely addicted. So we've got things like cans. So this really nicely, if I put that here, it's just opened up the can for me. So that again really helps, rather than me getting in there and pulling with my fingers. If you've got arthritis in your DRP joints or in your metatarsal. And similar sort of thing here with pen grips. So with pen grips, if we make sure, I always use, in fact, pens with a flowing ink and a nice rubberized end. I literally could not do a 10-hour clinic of writing my notes or whatever, because I still like to write my notes. Dinosaur, I know. Then this gets me through the day. But the alternative is to add a nice pen grip, and the difference in force that you have to put on with and without a pen grip is massive. I also, of course, suggest that people, this is an HB pencil, but I would suggest going to a 2B, because again, it's a softer pencil, so you'll get more of a effortless writing. And then finally, just to show you, I just bought a couple of these. I don't know if you've ever seen these. They're really useful for things like cutlery. They've got different size holes in them. So if you're wanting to improve somebody's grip onto an item, For example, just imagine that this was a fork. I could cut myself a piece of, I think it would be the red, would be about right for that. And I can slide the end of my fork into it, and now the effort to hold is significantly less, and we're maintaining that really lovely arch of the hand to be able to get the fork to mouth. So that was really, I hope, around the farming, well, 45 minutes. We wanted to leave 15 minutes for questions, because last time there were loads of questions. So I'm just going to, while Wissam just has a quick look at the questions that have been coming in. And if you want to just put it into the chat, any questions, we will have a look at them. I'm just going to reach over and get splints so that we can talk about these. Do we have any questions?
Yes, we do. Right, so the first question is, would you use K-tape for splinting a swollen thumb, MCPJ area, thinner eminence area that is swollen?
Okay, would I use K-tape for swelling? Yes, I would, but not either of the ways I just did. So let me show you. If you've got swelling, then I would use a different technique. So I'm going to cut a piece of this tape. If I move these out of the way. Okay, so I'm going to turn this into a half octopus. Let's see what I mean in a minute. So I'm going to curve the edge, and I'm going to make my octopus have lots of legs. Probably 4 or 5 out of these. Now, obviously, it depends where the swelling is, exactly what you would do. But if I can borrow your thumb, if we've got swelling around the femur here, then what I would probably do is bring the head of the octopus around the vulvar part of the wrist down here. And then, again, I'm tearing each one. We're going to use a zigzaggy sort of roundabout. Now I'm putting very, very little, about 15% maximum tension onto the tape. Now, it doesn't matter where I go, so you can be as creative as you like. So bring that forwards, round. You can see this okay. Oops. It's easier to do the order. All better. What you're wanting to do is create space between them all. And the idea with this is that it just slightly increases the interstitial spaces. So there's a little bit more space for the edema by lifting the outer layers of the skin in order that you can allow more movement underneath. And now as you move, if you just move around, it shouldn't restrict anything. To have a good movement around, you can see it's just lift. If you look here and in here, you can see it's just allowing the skin to just lift a little bit. Can you feel that lift? Yeah, it's a really weird feeling. Okay. Obviously, I haven't washed the hand first, and I haven't rubbed it, so it's not going to stay on very well. But that's essentially what I would do for a lymphatic thumb application.
Perfect. Second question, why do you work in circumduction with exercises?
Okay, so I don't only work in circumduction for exercises. I work in all sorts of directions. We don't have time to go through everything, but with osteoarthritis, it's really important to maintain this web space. So I will always be teaching people to restore back that, if they can, or at least maintain the ability for the thumb to go from, if you look at the nail is perpendicular. When it sits here in extension, it's perpendicular to the nail of the index finger. What we should be able to do is to bring the thumb around and oppose to the tip of the thumb with the two nails directly opposite each other. Now you'll see with people with arthritis at the base of their thumbs that they lose that ability and they end up coming to the side of the finger, or the nails are not in alignment here. So I'm trying to get people to do this to really make sure that stability is maintained. And I do little exercises such as using a table tennis ball. So, and you can see I put numbers on this. So I'll always get somebody to be working, and I'll get them to find one. So they're always working towards circumduction, away. So abduction, not adduction. So not working this way, they're always working this way. And I do the same with a tennis ball, which is a bit bigger, following the line all the way around, always working the thumb outwards. It's just a little bit more interesting than just, I mean, let's face it, exercises you have to do every day, it just get a bit tedious.
Next question. Can you repeat the first thumb test? Look for the C shape. Compare thumb radial.
Yes, I can. Okay, so the question was, can I just repeat the first thing that I look for in terms of the osteoarthritis? There are lots of little things to look for. So you're looking for, do you have what's called the shoulder sign? It's a bit ridiculous name for something that's going on with the thumb, to call it the shoulder sign, but essentially that's where the thumb is sitting palmally, volally into the palm. So in fact, if you look at my two thumbs, I don't know if you can see those. Yeah. This hand, my left hand, I have more of an ability still to get my thumb fully into extension. But if I try here, this is identical. I cannot get this thumb back here anymore. It won't go. I mean, I could push it, but it won't go. All right. So that's the first thing to look for. Second thing is I'm looking at what sort of a shape do I have here. Now, in a normal hand, you should have a really lovely C shape that's possible in here as you go into abduction. Again, as that thumb falls palmally, the thumb adducts and you end up with more of a V shape here. So just look for that. Are they able to? So they're trying to imagine, here we go, let's use this again, going around a glass, going around a pint glass, going around a wine glass. That's what we're looking for here. Now, the last thing I showed you was in extension rather than abduction. In extension, get the two hands together. You can just see my lovely new assistive. You can see my two hands together, and I hope you can see from above that my right, does that look right? You can see my right thumb does not go back as far as my left thumb does. It was really an insignificant difference to start with, and slowly, 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 I am losing it, and it's going to end up shorter and shorter. So those are the little things that you can look for.
The next question, please, can you show the templates out flat on the table?
The templates for the splints.
I'm assuming. So.
I can, I think. Okay, can we show the templates of the splints out on the table? I can show you all but one. I don't quite know what happened to one, but I can draw that one. Well, that was the one that I drew out, but I can draw it out again. So if I actually, what would be sensible is if I, I'm just using this so that I don't go through onto the towel. If I take a pattern again, if I may, put my nice up here. So if we take a pattern again, and I'll show you then how they overlay, because it's got to be in context, hasn't it? So here's my MCP, IP joints, MCP, CMC, wrist, and we can now lift off. That's brilliant. Okay, so now let's start with the simplest. The simplest, which would be this splint here. So that's the one. If you'd like to model it for me, that would be marvelous. And that fits with the point of the thumb here So we're going across where the IP joint is, down to where the web space is, and here's my little flap. This is the opposite of your thenar, and now we're coming over the back of the hand, and that ends up with a splint like so. Okay, brilliant, thank you. Let's pop that one off. Then if we do the same one, but with the extra bit around the back of it, we've got this one here. So the same, we've got, if you imagine, here was this one. And now if I take that away, the extra bit is over the back of the thumb. Remember, I actually did that in situ because it was easier. So here we have over the back of the IP joint. So that splint turns into this one. Now that one is the one that we took off before it really had fixed in position. So I don't know if it, oh, it does. There we go. Let's go from top right. We took this off earlier, remember, because it didn't, and it's gone flat on the back because I just put it down on the table. But you can see here, it's identical at this end of the splint, but the difference is we've now got a back piece on the back of the IP joint so that it gives some support. If we turn that the other way up, you can see she's got good and free movement of the IP joint, but a block dorsally. So that was that one, brilliant. Pop that one off, thank you. Then we've got the next one, which is the CMC only. Again, all of them are identical when it comes to this section here. So you've got your opposite to the thenar, coming over dorsal and hooks around the ulnar. Remember, it can be shorter if you don't want to have anything on the ulnar border. And this is the bit that loops down underneath the MCP joint and reconnects up onto here. So we end up with that as our 3D, and here is that one. Pop that one on. So you can see that one. And again, it scoops really nicely. It's got really nice motion. We've got support of the CMC joint. Brilliant. And then the last one is identical. Again, here was this original. There. I take that away. We've got the same, but I've built the extra piece here to support the back of the MP joint. And that is this one. So again, it supports underneath. We get free motion there. I probably would have moved this away. Sorry, can you see? Probably would have just rolled this down a little bit more so she's got better freedom of movement of the MCP joint there, but now we've got block to stop the hyperextension. So this splint design would work really super well for me. And of course, I could extend it along and block over the back of the IP joint as well. It's just really important to think about the biomechanics. So that you're not solving one joint problem and actually exacerbating the other with arthritis or indeed with hypermobility. Sorry, that was a really bad angle. There we go. And then the last one was this one, which I actually showed you anyway, I think. So that was the one that we drew out together, and that's the long thumb.
Perfect. We have less than 2 minutes, quite a lot of questions to answer. So we're going to be able to take one more question and then answer the rest next week, if that's okay, via email.
Yep.
The next question is, and the last question is, at which point would you move into surgery for thumb CMC OA? And do you think it's always worth trying splinting and rehab first? 100%.
So the question was, at what point do we suggest moving on to surgery for OA CMC? So if you look at the Eaton-Littler classification of OA of the thumb, 4 stages, 1, 2, 3, and 4. Mine's probably between a 1 and a 2 now. The evidence has shown that if you're treating thumbs that are at stages 1 and 2, therapy is hugely successful, And there's a fabulous paper that was written. Again, you can email if you want the reference. That was done in Scandinavia, where unusually for their health system, they had a waiting list of people. So they have people who've already been consented for a trapeziectomy who were having to wait. So what they did was they sent them all off for hand therapy as a, we're really sorry you're having to wait. And in a, I can't remember if it was a 7 or a 10-year follow-up, but a significant follow-up, 70% of them chose not to have the surgery because the hand therapy had been that successful. So my first port of call, always with grades 1, 2, and possibly early 3s, would be to go for hand therapy. 3 pillars: splinting, exercise, joint protection techniques, with a little bit of help from things like heat, ice, kinesiology tape, etc. And only then do I think you lead somebody off to a surgeon. We've got to the end of our hour. I think we've got about 15 seconds left. So first of all, for me to just say thank you very much to my lovely assistant here, who allowed me to cover her in everything this afternoon. And I hope that's been useful. The questions that were left over, I will try and address those in the next week or so. And I look forward to seeing you all again for the next Performance Health webinar soon. Have a lovely afternoon.